Good morning, everyone. I will be presenting a paper on tele-ophthalmology, a model for eye care delivery system in rural areas of South Gujarat. Tele-ophthalmology is a community outreach program. In rural and tribal areas of India, lack of ophthalmologists or proper infrastructure has led to delay in the diagnosis of preventable causes of blindness. It can also be particularly helpful during the recent COVID-19 pandemic to decrease in-person consultation and maintain social distancing. Teleconsultation can evaluate the patient similar to face-to-face consultation through video conferencing and help identify the ones who are truly in need of an expert ophthalmologist care. Furthermore, this model also allows the patient to avail eye care near to their homes and avoid significant burden of travel and loss of daily wages. Thus, it can prove to be more cost-effective and saves time and effort of both patients as well as experts. So the aim of the present study is to explore the role of tele-ophthalmology as a model for detection of eye disorders in rural and tribal areas of Gujarat having limited access to ophthalmic care. It was a prospective observational cross-sectional study conducted during May 2021 to July 2021 during for 3 months of duration, and it included 8 vision centers and 3 satellite centers of the hospital in the nearby rural and tribal regions linked to the base hospital via tele-ophthalmological means. All the patients who underwent teleconsultation during the study period and who gave the consent were included in the study, and patients who refused to provide the consent were excluded from the study. Preliminary information of the patient was recorded upon visit, followed by clinical examination carried out by the trained ophthalmic assistant present at each center. The live feed of the examination was transmitted to the base hospital along with the detail of the patient. The ophthalmologist at the base hospital evaluated the clinical data and interacted with the patient and the technician via real-time video conferencing. These are the results. A total 1,000 teleconsultations were conducted during the study period, and the majority of the patients were from age group 41 to 70 years. Out of the 1,000 eye examination, 51% were female and 49% were male. Combining all the examination from the 11 centers, 65.2% patients were from tribal community, while 34.8% patients were non-tribals. So out of the 1,000 patients, majority of patients were of cataract, followed by refractive error, constituting 30.1% and 29% respectively. 42.1% of the patients were referred to the base hospital for further evaluation. So it saved the visit of 57.9% of the patients, out of which 15.1% were provided medical treatment at the center, 29% were given glasses at the vision center, 9.7% of the patients were called for follow-up at the center, and ophthalmic examination of 4.1% of the patients were within normal limits. This model is found to be feasible, cost-effective and acceptable in our study and agrees with Pratibha and Rema to apply tele-ophthalmology as an effective model for eye care in rural and underserved areas in India. Our data indicate that maximum number of patients who came for teleconsultation for visual impairment were having either cataract or uncorrected refractive errors. Similar results were found in another study conducted by Shankara Nethralaya in rural regions of South India. Timely assessment of the cataract and respective referral to the base hospital can lead to significant reduction in the preventable blindness in such underserved regions. In current study, glasses were provided to 290 of the patients with uncorrected refractive errors, suggesting an important step towards correction of error and thereby prevention of visual impairment. Additionally, several patients were detected with treatable medical conditions like conjunctivitis, tyche, lesion, and blepharitis. These were counseled and provided medical treatment at the vision center itself. So it helped in saving the time and money of the patients. Our data indicate 1.7% of the patients detected with glaucoma. A meta-analysis suggested that greater number of cases of glaucoma were detected using tele-ophthalmology than in-person examination. In the present study, majority of retinal cases were diabetic retinopathy followed by dry ARMD. Recent meta-analysis also suggests that tele-retinal screening showed high accuracy in terms of sensitivity and specificity in comparison to traditional face-to-face examination. So to conclude, the teleophthalmology is an acceptable and feasible tool for providing eye care in rural and tribal regions of Gujarat where access to expert ophthalmologists is not possible. Although challenges still exist, the pandemic has accelerated the adoption of teleophthalmology. As a result, it will play an integral role in providing high quality, efficient care. These are my references. Thank you.
Good. I think it was a nice presentation. Teleophthalmology is the need of the hour. What are the drawbacks of teleophthalmology?
There is a need for a high initial investment, the cost of the investment, then poor quality of the images, the patient's concern regarding the accuracy.
What are the medico-legal aspects? Medico-legal aspects when you are checking the patient via teleophthalmology. Okay, just
You were there on both the ends, which kind of human resource
young kid.
there on both the ends?
She said some optometrist was there, isn't it?
Ophthalmic assistant is,
more ophthalmologist
Diagnose
than
the ARMD?
sir.
Have you trained enough of them to diagnose the ARMD also? You're saying that patients prefer
They
to-
just showed the fundus picture.
Fundus picture.
And on other side, was it only slit lamp or camera mount?
It was a camera mount.
Camera mount.
Yes.
Retinal camera was there,
Yeah.
fundus picture was there.
Okay.
I think you, yeah. Hey, please.
I have one question. You said 35-40% was cataract.
Yes.
Post-operative evaluation was done by teleopthal or
Yes.
visits
Yes.
to the
The
center?
first post-op visit, it was at the base hospital. Then the subsequent visit were at the vision centers.
Okay, I think I'll just add, you did well. The study design, that is a very important part in presentations because this is all new presenters. So you mentioned the study design, that was good. And sometimes the sample size or how, because it's a prospective study, you must say that how it was selected, 1,000 or maybe time bound, you can say that. You just can't say, 1000 ho gaya, band karo. That's not acceptable very highly. And about observation is that you said cataract, fine, cataract is most, in all our studies, but I think it would be useful if you see what were the cataracts 3+, 4+, which needed early, so that this teleophthalmology helped them, helped the society or the ophthalmologists. I think that would be interesting.
Thank
I
you.
think last couple of years it was not physical conference of All India Ophthalmological Society and we were on the Zoom platform. So the difference of physical conference and online conference, the same way teleophthalmology and exactly checking the patient in front of each other. Another thing is about artificial intelligence, and nowadays every technology is trying to replace the human intelligence, and that shouldn't happen. Our skills of ophthalmologists, they are very important. Of course, such technologies like teleophthalmology, artificial intelligence, definitely they will be running parallel hand in hand. So we must try to meet both ends all together and reach to the nice conclusion for the betterment of society and patients.